The following podcast is part of a certified educational activity titled Fortifying the Framework for HER2+ GI Cancers, Precision Treatment Planning with Molecularly Targeted Therapies in GC, GEJC, CRC, and BTC. Access the entire activity and complete the post-test at peerview.com/XJJ860. Downloadable slides and practice aids are also available.
Hello and good evening. It's actually great to see such a big crowd here at the end of a Friday night, and hopefully we'll make it worth your while in terms of imparting new information about kind of the exploding field of HER2 therapies in GI cancers. So therefore, the premise of this talk is really precision treatment planning with molecularly targeted therapies in gastric cancer, GE junction cancer, colorectal cancer, and biliary tract cancer. So tonight's panelists is myself, Dr. Shubham Pant and Dr. Kanwal Raghav. So these are the goals for today. We are hoping to enhance your understanding of the significance of biomarkers, molecular profiling techniques, and the scientific rationale for HER2-directed therapies in the cancers previously mentioned, improve your knowledge of the latest safety, efficacy, evidence, and guideline recommendations on the use of targeted therapies for the management of HER2-expressing GI malignancies, equip your skills to personalize treatment plans with targeted therapies in HER2-positive GI malignancies that consider molecular findings, safety/efficacy data from clinical trials, and practice guidelines. And finally, to provide you with tools to address the practicalities of treatment planning in HER2-positive GI malignancies, including best practices for treatment-related adverse event management, care team coordination, and patient education. So without further ado, let me start by talking about the overall treatment in HER2-positive GI cancers, the role of molecular testing to direct treatment planning. So it's pretty clear now that HER2 is an established therapeutic target found across a variety of solid tumors, and very importantly, it is now an agnostic biomarker with pan-tumor approvals irrespective of tumor subtype. There are a number of novel HER2-targeted therapies that are being evaluated in GI cancers, and therefore it's incumbent upon us as practitioners to understand the need for broader HER2 testing. So this is an analysis from the Netherlands of patients with gastric cancer, and thankfully we see that over time the incidence of HER2 testing has increased from a low level of 18% in 2010, which is when the TOGA study was initially published, to 88% in 2016. Over this period of time, survival has also increased, but nevertheless, only 77% of patients in this series who are HER2 positive actually received trastuzumab-based therapy. And I'm hoping that I'm preaching to the choir, but median overall survival in patients who are HER2 positive was higher than patients who are HER2 negative, clearly implying the benefit of trastuzumab-based therapy and targeted therapy based on biomarker testing. So this is a summary, of course, of HER2. So HER2, as we know, is actually one of a member of 4 proteins, EGFR or ERBB1, HER2, of course, ERBB2, and also there are 2 other family members. These basically exist as heterodimers, meaning that they need to come together before there's downstream activation, and each can bind with the others, but HER2 is the preferred binding partner for all of the other proteins. Again, this is aberrantly activated in multiple cancers and now is a well-established therapeutic target. So this is a brief summary of the expanding list of agents that target HER2. We're, of course, familiar with the single epitope antibodies such as trastuzumab as well as pertuzumab. At the far right, we have bispecific antibodies, zanidatamab, which is a bispecific or biparatopic antibody that you'll hear about more later today. There are, of course, antibody-drug conjugates, such as trastuzumab deruxtecan, that we will discuss in detail across the multiple tumor types. And of course, there are also TKIs, such as lapatinib, neratinib, and tucatinib. So in totality, there are now multiple ways of targeting HER2, and sometimes we employ combinatorial strategies. So this is the molecular testing considerations for HER2, certainly as it relates in gastric, but also all other sites. So I think all of us are most familiar with the use of IHC and FISH, which really has been the standard of care. The advantage is that it has a relatively rapid turnaround and low cost and is widely available virtually everywhere. Now, the major disadvantage of IHC FISH is that it can be considered a standalone test. In other words, you're checking off boxes, ordering HER2, MMR, PD-L1, and other biomarkers, unless it's part of a reflexive panel. And I would certainly encourage that everyone here, discuss with their pathologists or pathology colleagues to see whether there can be reflexive testing depending on the tumor type. Now, a disadvantage of IHC and FISH is that it misses out on the possibility of tumor heterogeneity. In other words, primary tumor is HER2 positive or HER2 negative, while liver metastasis has a different status. The next test that I think we're all familiar with, of course, is next-generation sequencing. And of course, the benefit is that this is comprehensive genomic testing that allows testing of 500 genes or more. And one of the benefits is that it does allow for the detection of potential resistant variants to HER2 therapy, although the implications of this remain largely investigational at this point. Downsides, longer wait time, higher cost, and it does potentially have a lower sensitivity than FISH. And again, just like IHC and FISH, testing the tumor itself misses the possibility of tumor heterogeneity. Finally, I think ctDNA is a new kid on the block, and certainly there's a lot of enthusiasm. Of course, the benefits does not require tumor tissue or biopsy. You can perform ctDNA testing at multiple time points. A strong benefit is that it's not confounded by tumor heterogeneity and really is a summation of all of the alterations that are found in the tumor. It can also be used in real time to detect the emergence of resistant mechanisms, although again, this really remains investigational at this point. Downsides, longer wait time and cost than IHC. And at this point, the sensitivity and specificity versus standard IHC and FISH really remains undefined across multiple tumor types. And ultimately, it's not generally considered as an accepted screening test for most experimental studies, which still rely on IHC and FISH. So my take-home in terms of this kind of mix of different testing is that liquid biopsy, I think, has the potential over the next couple of years to become a very powerful tool, not only for screening of HER2 status, but really to monitor and better understand the evolution of resistance. For now, I would state that it really should only be used as a complement to IHC and FISH, which remain standard, or potentially NGS. So use a complement, but not as primary testing. So I think all of us understand that molecular testing is important, but certainly patients have that understanding as well. Here you see what patients think about this. Clearly, when it comes to molecular testing, they're interested in the potential benefits. They certainly want to know how that changes treatment. They want to know how that has implications for family members, and that's potentially relevant in something like MMR testing, where you could potentially identify underlying HMPCC or Lynch syndrome. And of course, patients are also worried about how this informs their prognosis, and therefore it's important to convey this information to patients. So after that general introduction, I'll start focusing on gastric cancer and GE junction cancer. So I think this is always a sobering slide, but I think it really highlights the fact that there remain inadequacies in HER2 testing at this point, and it's at this point 15 years after the TOGA results. But reliably, typically, 1 in 4 or 1 in 3 patients may still not undergo HER2 testing. And even in patients who are HER2 positive, only about 60 to 70% actually receive trastuzumab therapy in the first line. And it also goes without saying that unfortunately, patients drop off, and in the proportion of patients who are able to receive second and third line therapy, also, the proportion who are not able to receive treatment increases over each line of treatment. So therefore, a strong reminder is that it's absolutely critical to perform biomarker testing on all of our patients. Now, an important note is that HER2 expression and staining is really different in gastric and GE junction than in breast cancer, but also even in other sites in the GI tract, including colon cancer. And one of the major differences is that there's much greater heterogeneity, and so therefore there's a higher rate of false negative testing, and therefore it's really important that any sample that be submitted be adequate. Technically, HER2 protein expression is typically absent in the digestive luminal membrane, so that it's not circumferential staining, and the pattern is this so-called basolateral pattern. Right? Because of all these differences, it's really important that the staining be done by an expert pathologist, and that when requesting staining, that you're requesting staining using gastric criteria as opposed to breast or other sites criteria. So the question is, who should undergo testing for HER2? And these are kind of the recommendations from different guidelines in Europe, Japan, as well as ASCO and NCCN. I think the bottom line is that clearly all patients with metastatic disease should undergo HER2 testing. When there is an established role for HER2 therapy, patients should undergo HER2 testing. And in addition, and this is something that we'll talk about, NCCN actually recommends that repeat testing be considered at the time of clinical or radiographic progression, and we'll discuss the rationale for this and why it is important to test a progressive lesion at the time of progression on trastuzumab-based therapy. So this is a reminder of the current treatment algorithm, and actually it's an important reminder because on a regular basis I still see testing performed, either with FISH testing or sometimes actually, again, even using criteria for breast cancer as opposed to gastric cancer. So there is a hierarchical testing that should be performed, and we should start with immunohistochemistry, which again is a relatively cheap test that has a turnaround of several days. If you end up with an IHC score of 3, that is a HER2 positive tumor, and you're done, and you can proceed to discuss trastuzumab-based therapy. On the other hand, if the IHC score is 0 to 1, that is a flatly HER2 negative tumor, no additional testing is negative, and you can discuss therapies for HER2 negative disease. Here it says, platinum fluoropyridine plus minus docetaxel. This is based on German guidelines. We would rarely use a 3-drug regimen like this in the metastatic setting, but certainly HER2 negative therapy is appropriate. Now, the one circumstance when we would consider reflexive FISH is if the IHC score is 2+ or intermediate. And in that case, if the FISH results are positive, that's a HER2 positive tumor. If the FISH results are negative, that's a HER2 negative tumor. So these are the 3 therapies that are currently FDA approved for treating HER2-positive esophageal gastric cancer: trastuzumab, pembrolizumab, trastuzumab, and trastuzumab deruxtecan, or T-DXd. And over the next several minutes, I hope to discuss the data for each of these 3 therapies. These are also the NCCN guidelines, which are listed here. Of note, trastuzumab deruxtecan is approved as second-line or subsequent treatment. And again, I'll explore the data supporting this NCCN recommendation. So we'll start with kind of the granddaddy of all studies, which is the TOGA study. And the important landmark study is notable for a couple of reasons. It was the first study that established a benefit for a targeted therapy in gastric cancer. It was also the first study where the overall survival crossed the psychological 1-year barrier. So again, this is a study that's 15 years old at this point. But nearly 600 patients were randomized to receive chemotherapy with or without trastuzumab. And you can see from the Kaplan-Meier curve on the right that there was a clear improvement in overall survival, as well as all other outcomes for the addition of trastuzumab to chemotherapy. Now, an important reminder about the study is that in the original intention to treat population, patients were considered HER2 positive if they were IHC 3+ or if they had FISH amplification. But in a planned post-hoc analysis, the focus was on what we now consider the contemporary definition of HER2 positivity: IHC 3+ or IHC 2+ and FISH positive. And you can see from the subgroup analysis that these patients derived much more benefit than patients who were FISH positive but only 0 or 1+. So at the time in the US, the regulatory approval was actually based on the intention to treat population. In Europe, it was based on this exploratory subgroup analysis, but we all, of course, now recognize that this is the contemporary definition of HER2 positivity. So the next study, of course, that I think all of us are familiar with is the KEYNOTE-811 study. So this was a study that then randomized patients who were HER2 positive to either trastuzumab and chemotherapy or to the addition of pembrolizumab. The study has been presented various times. In fact, the initial approval was based on an improvement in response rates alone. And this is the most recent final analysis from ESMO 2024 last fall. So if you look at the Kaplan-Meier curves, and this is the intention to treat population, you see that there's a clear separation of curves, and therefore a modest improvement in outcomes with the addition of pembrolizumab to trastuzumab and chemotherapy. Now, we also see a similar improvement in response rates of about 13% for the addition of pembrolizumab, and there was also a longer duration of response in the pembrolizumab patients. Now, I think many are aware that in November of 2023, the FDA approval was actually narrowed. Initially, the approval was in all patients, irrespective of CPS, But in November 2023, at an interim analysis, it was clear that the CPS 1 or more patients benefited, whereas the CPS less than 1 patients, which really comprised only 15% of patients in the study, did not seem to derive any benefit. So at that time, the approval again was restricted, so that today this is an option only for patients who are HER2 positive and have a PD-L1 CPS of 1 or more. Now, in terms of mechanisms of resistance, we know that in addition to HER2 amplification, there can be corresponding or co-mutations in other pathways, including the RTK, RAS, PI3 kinase pathway. And the presence of these co-mutations leads to shorter progression-free survival in patients who receive trastuzumab. At the same time, a very important mechanism of resistance is actually the loss of HER2. So in numerous studies, it's now been demonstrated that if a tumor progresses on trastuzumab-based therapy, when we rebiopsy these tumors, actually up to 30% of the time there's loss of HER2, and therefore that's a mechanism of resistance. So certainly it is an absolutely strong consideration to rebiopsy at the time of progression on trastuzumab to make sure the target is still there before we consider additional anti-HER2 therapy or other therapy that does not depend on the HER2 inhibition. So the next treatment to talk about is trastuzumab deruxtecan, which I think all of us are now familiar with. So as a brief summary, it's an antibody-drug conjugate of trastuzumab with a very potent topoisomerase inhibitor. And there are potential advantages of T-DXd over other ADCs. First of all, the topoisomerase inhibitor is extremely potent. There's also a very high ratio the high ratio of payload to trastuzumab molecules is about 8:1. And then what's particularly relevant in gastric cancer is that there is a potential for this bystander effect. And what this means is that when the T-DXd gets internalized into a HER2-positive cancer cell, the topoisomerase inhibitor, the deruxtecan, actually separates from the trastuzumab and can diffuse into neighboring cells. And if you have a tumor that's heterogeneous, where a HER2-positive cell is surrounded by some HER2-negative cells, that may be a particularly relevant mechanism of cell kill when it comes to stomach cancer. So T-DXd was evaluated, has been evaluated in 2 studies, which is DESTINY-Gastric-01 and DESTINY-Gastric-02. If you look at the efficacy data on the left, it's essentially similar. I'll go into the study details in a minute. But both studies report a confirmed objective response rate of about 40%, a duration of response of about 8 months, and that translates into a median progression-free survival of about 5 to 6 months, with a median overall survival of about 12 months. Now, it's surprising and pleasantly so that both of these results are similar because both studies are quite dissimilar. So DESTINY-Gastric-01, as the number implies, was actually the first study, and this is a study that was performed exclusively in East Asian patients in Japan and South Korea, and it was a third-line study. Patients had to have progressed on 2 lines of treatment, and they were actually randomized to receive T-DXd versus a dealer's choice of irinotecan or a taxane. On the other hand, DESTINY-Gastric-02 launched after DESTINY-Gastric-01, but it was a single-arm phase 2 study that was performed exclusively in the US and Europe, and it was a second-line study and required progression only on first-line trastuzumab-based therapy. Notably, DESTINY-Gastric-02 required a pre-treatment biopsy. In other words, before patients could be enrolled on this study, they had to have a biopsy post-trastuzumab to confirm persistent HER2 positivity. So despite the very different characteristics of both of these studies in the patient populations, it's actually very reassuring to know that the results are very similar, which really highlights the durability and activity of T-DXd. So toxicities of T-DXd, so at the end of the day, I think sometimes we forget that we forget the drug in the antibody-drug conjugate because it is chemotherapy after all. So it has all of the normal chemotherapy toxicities, including myelosuppression. I would also emphasize that nausea, vomiting, I think is an underappreciated toxicity. This is a moderately emetogenic medication, and we typically administer it both with palonosetron as well as aprepitant. And of course, there is a much feared toxicity that I'll come back to in the next couple of slides. So based on DESTINY-Gastric-01 and 02, this is the status of global approvals. So based on DESTINY-Gastric-01, T-DXd was actually approved in Japan in September of 2020, but it was approved as third-line or later therapy. Based on both DESTINY-Gastric 01 as well as 02, T-DXd has been approved in the US as well as in Europe. Again, a second-line or later therapy, so in other words, you don't have to wait until third line to give it. There are 2 other studies that are underway, and we can certainly discuss these studies in the Q&A session. DESTINY-Gastric 03 is actually evaluating T-DXd in combination with chemotherapy as well as immunotherapy combinations in the first and second line setting. And DESTINY-Gastric 04 actually is a phase 3 study that is evaluating second-line T-DXd versus the other standard of ramucirumab and paclitaxel. This is a study that's not open in the US because T-DXd is available as second-line therapy in the US. So I already mentioned that T-DXd does have substantial nausea and vomiting, so I think it is important to proactively manage that, meaning add antiemetics during therapy, and also making sure that patients have any number of antiemetics at home. And increasingly, we use olanzapine. Dexamethasone can be considered, but certainly other antiemetics such as metoclopramide, prochlorperazine. So this is the kind of dreaded toxicity that I had alluded to, and this is something that's been seen in every single study with T-DXd. So there's about a 10% risk of interstitial lung disease or pneumonitis. Some of it is grade 1, meaning that it's apparent only on imaging and patients are entirely asymptomatic. But there are grade 2 through 4 and even grade 5 events. So I really like this kind of this acronym, the 5 S's for trying to manage interstitial lung disease. First of all, I think screening is important. In other words, at every single visit, it's important to check to see whether patients have any respiratory symptoms. Number 2, scanning. So again, sometimes because it's grade 1, meaning that patients are asymptomatic, it's something that you pick up when you check a repeat CAT scan to see how patients are doing on treatment. And again, you notice some ground glass opacities on imaging, and in the absence of some other explanation, an infection, progression of disease with lymphocytic carcinomatosis, it really would be consistent with interstitial lung disease from T-DXd and actually has to be managed very aggressively, even though it's a grade 1 toxicity. I think synergy is really important. I think hopefully at all of your practices and institutions, you can identify a pulmonologist who can become the de facto expert in managing ILD, so that if there are any symptoms, if there are any findings that are of concern, you can immediately refer to them. Now, suspending treatment is really an important point. So again, we'll go over this in the next slide, but even grade 1 pneumonitis or ILD has to be treated aggressively with holding the T-DXd. It's not a situation where you can say, well, this patient is asymptomatic, let me just continue the treatments and get another scan at a short interval. And then ultimately, if ILD is diagnosed by excluding other etiologies, again, infection, progression of disease, inflammation from other causes, steroids is really the mainstay of treatment for ILD. So again, this is the management. If someone has grade 1 ILD, you have to hold treatment until it resolves to grade 0, meaning that you repeat a CAT scan and all of these inflammatory changes have gone away. Steroids are not mandatory, especially because patients are asymptomatic, but it's a consideration. And again, patients really need to be co-managed with an experienced pulmonologist. And this is kind of the dose holding or kind of dose modification. Now, if the symptoms resolve within 4 weeks, you can keep the dose. But if it takes more than 4 weeks for the grade 1 findings to resolve, you should reduce by 1 dose level. And if the grade 1 findings actually last for more than 7 weeks, the drug should actually be permanently discontinued. For any other grade of ILD, grades 2 to 4, T-DXd should be permanently discontinued. So again, this is a much more rigorous and aggressive or conservative management than, for example, the pneumonitis that we see with immunotherapy. Otherwise, I think in terms of a final summation, there are new and emerging anti-HER2 therapies. I think at this conference, we've heard about zanidatamab in gastric cancer. There is a phase 3 study that is very close to completing accrual. We'll hear about zanidatamab in biliary tract and at other sites. Evorpacept is also a compound that kind of was mentioned at this meeting in the ASPEN-06 study. It's an anti-CD47 antibody, or what's referred to as a "don't eat me" antibody. And this is a molecule that's expressed on macrophages. So in this study, it was added to trastuzumab, ramucirumab, and paclitaxel. The results were presented by Dr. Shitara, and there certainly was a hint of activity in patients who were clearly HER2 positive. Otherwise, there are newer ADCs that are being developed. There are HER2 CD3 bispecific or BiTE antibodies. There's even HER2 cellular therapy that's now being slowly evaluated. So to finish, I'm going to present a patient case. Again, a very typical patient that I would see in clinic. It's a 65-year-old man, thankfully with an excellent performance status. He's had lingering dysphagia for many, many months that has slowly worsened, and over this period of time, he's actually lost 5 kilograms. Ultimately, he undergoes an endoscopy which reveals a GE junction mass. The biopsy shows a moderately differentiated adenocarcinoma. He immediately has a CT scan which shows 2 liver lesions consistent with metastases, a large gastrohepatic nodal mass, as well as thickening at the GE junction. And shortly after the CT scan, biomarker testing reveals that the tumor cells are HER2 positive, IHC3+, and also have a PD-L1 CPS of 7. So at this point, what would you recommend in the frontline setting? I guess because he's closer to me, I'll ask Dr. Raghav.
Yeah, I think in this case, I would recommend choice number 1, pembrolizumab, trastuzumab with chemo, because of the HER2 positivity as well as the CPS score that's greater than 1.
Yeah, I mean, I think that absolutely we would agree with that. I think it would represent the standard of care at this point in time, and I think unless there was a specific contraindication for an immune checkpoint inhibitor, that clearly would be, I think, the most appropriate option. So indeed, the patient initiates treatment with pembrolizumab and FOLFOX chemotherapy, and very gratifyingly, his dysphagia improves even with the first cycle, eventually resolves, and he actually regains all the weight that he lost. And a CT scan at 2 months does reveal decrease in size of the liver metastases, the lymph nodes, as well as thickening of the GE junction. He then continues on this treatment until 8 months later, when a CT scan now shows that one of the liver metastases is beginning to grow, and he is beginning to develop recurrent mild dysphagia symptoms. So I will ask Dr. Pant, at this point, what of these 3 options would you consider? And actually, maybe let me open it up to the both of you, because in full disclosure, I think any of these options are potentially defensible.
Well, I think it's a trick question, right?
Yeah.
So I think, you could choose either one of them. So I would probably biopsy it and check if it's still HER2 amplified, and then think of the therapy after that. Or you could do a ctDNA again, it's HER2 amplified, then think about the therapy after that. So I would go for 2 or 3 followed by 1.
Yeah, Raghav, what do you think?
Yeah, I think it's reasonable. If it's a biopsyable lesion, that would be my number 1 go-to. You can also use sort of ctDNA as a screening measure, because if it's positive, then you know your answer.
Right.
But this patient also has like a really small time for which they were treated on anti-HER2 therapy. So probably HER2 loss has not really occurred in this setting. So trastuzumab deruxtecan, if clinically you can't, get a biopsy, would be very reasonable.
Yeah, no, so I think all 3 options are absolutely applicable. So I mean, I would say that I think in my practice, I try very much to biopsy. In this case, if he has worsening dysphagia, it's a good chance that the primary tumor is progressing. So you can certainly, an endoscopy biopsy is probably safest and quickest. If not, an IR-guided biopsy of a liver metastasis is possible. Now, there are circumstances when it's a retroperitoneal lymph node that's progressing and it's not easy to biopsy. So I think as a surrogate, I would consider checking ctDNA. And I think as long as it's positive, you know that some component of the cancer still remains HER2 positive. Again, notably, DESTINY-Gastric 01, which was the East Asian study, and when T-DXd was given as third-line treatment, actually did not mandate a biopsy. So I think some would defend and say that you don't necessarily need a biopsy, but again, I think when there's a 1 in 3 chance of HER2 loss, I think it absolutely makes sense for us to confirm that HER2 is still present before giving a treatment that's effective only against HER2. So I think either 2 or 3 would be appropriate. So again, this patient undergoes a repeat endoscopy with biopsy of the GE junction tumor, and thankfully it confirms that the tumor is still persistently HER2 positive, which is IHC3+. His performance status remains excellent, and he's eager to receive whatever treatment you recommend. So of the 2 options, T-DXd or ramucirumab paclitaxel, what would both of you consider?
I mean, I would recommend trastuzumab deruxtecan, but if it's not available, treatment with ramucirumab paclitaxel followed by trastuzumab deruxtecan is also a reasonable option, as was shown in the O2 study.
Yep.
Yeah.
I second that.
Okay, perfect. Yeah, and again, both options are reasonable. Again, in the US and Europe, well, focusing on the US, T-DXd is approved as second-line or beyond therapy. And of course, if we do cross-trial comparisons, response rate of 40% versus a response rate of 28% with ramucirumab paclitaxel, I think it's absolutely defensible to consider T-DXd. Having said that, technically, I think the jury is out. And again, DESTINY-Gastric 04 is a study being performed outside of the US that really is directly comparing both of these head-to-head. So that really will give us a definitive answer as to whether one is superior. But I think it really is a question of sequencing treatments. You can start with 1 and go to 2, or you can start with 2 and go to 1. All right, so to quickly summarize, in the interest of time, I'll quickly go over this, but when it comes to Keynote 811, I think all of us are familiar with the toxicities of trastuzumab as well as pembrolizumab. When it comes to T-DXd, again, ILD management is critical, but this is chemotherapy, and we have to watch out for nausea, vomiting, as well as myelosuppression. So I think final thoughts is, again, TOGA really established the standard of care. Now, based on Keynote 811, we add pembrolizumab for tumors that are PD-L1 positive. I think for patients with disease who progress on trastuzumab, strongly consider a repeat biopsy. And T-DXd can certainly be given in the second line or later settings. Certainly can be given regardless, it works irrespective of prior exposure to immunotherapy, but we've already discussed the very serious toxicities to watch out for. So I thank you very much for your time, and then now I will hand the stage over to my friend and colleague, Dr. Raghav. I will quickly add that I just learned earlier on this evening that both Dr. Raghav and Dr. Pant apparently jumped off a 20-foot cliff in Bermuda in the fall, so I might take anything they say with a grain of salt.
Thanks, Jeff. So, coming into this talk, we're going to talk about colorectal cancer. HER2 has been a player in breast as well as gastric cancer for a long period of time. But I think colorectal cancer, it's become a more recent evolving target because of its lower prevalence in CRC. However, it is an important target, as would be clear from the talk going forward. This slide is unfortunately the state of affairs currently, right? So this is biomarker testing in first-line therapy. And in colorectal cancer, only about 51% of the patients, or about 50% of the patients do not receive any biomarker testing that adheres to published guidelines. I think this needs to change. And 52% of the centers do not have actually any standard protocols for biomarker testing. At MD Anderson and most other centers, and as per recommendations, all patients with metastatic disease should get biomarker testing as early as possible. This is standard of care for breast, gastric, lung. There's no reason why this should not be the case for colorectal cancer. 40% of patients do not routinely use genetic counseling services for patients with CRC. So all of this points towards the fact that once the disease is diagnosed, most of our emphasis is on starting treatment, but there are other things that we need to do to optimize treatment goals. So colorectal cancer can be broadly divided into these molecular subsets, right? So on one hand, you have this large subset of RAS mutations. Then you have the deficient mismatch repair or MSI high group, which is the immunotherapy responsive group. You have BRAF V600E mutations, for which you'll see the data from Breakwater study, and Beacon is already a standard regime in second line. And then you have a small but significant subset of patients that are HER2 amplified. Now, although it seems like they are all different subsets, that's actually not true, because there is certain degree of overlap between MSI high and BRAF V600E mutations. But broadly speaking, BRAF and RAS mutations are mutually exclusive, and most HER2 amplifications are actually seen in RAS BRAF wild-type tumors, but there are some patients that have HER2 overexpression and amplification that will also have concomitant RAS mutations. So we'll just have to remember that, because it makes a difference in their management. So HER2 colorectal cancer is a very distinct subset of colorectal cancer. It's usually found on the left side. Most of the times, HER2 expression, even though it's GI and gastric is GI, the expression patterns are very similar to breast rather than GI. So there's a lot of bimodal distribution. You have these high expressors, and then you have very low expressors. But unlike gastric cancer, it's not as heterogeneous staining as is seen in gastric cancer. So these are not mutually exclusive with RAS or BRAF mutations, but enriched in BRAF and RAS wild-type tumors. And in colorectal cancer, one of the unique factors about this subset is they are at a very high risk for development of brain metastases. When I initially started treating HER2 disease in CRC, I never recognized this till the time we started actually doing scans for clinical trials as a part of eligibility, and we found that a large number of patients had occult brain metastases even at diagnosis. So HER2 overexpression is seen in about 2 to 3% of unselected colorectal cancer, but about 5 to 6% of RAS BRAF wild type will have this because there's greater degree of enrichment in that group. And when you look at all the methods of assessing HER2, you'll see that that prevalence factor ranges anywhere between 2 to 5%. HER2 can be assessed as in other disease types with IHC, which is most common. The staining patterns are usually an intensity score of 0, 1 plus, which is faint or no staining, and then you have moderate and intense staining, which is IHC 2 plus and 3 plus. This is protein expression. And then on top of it, just like in gastric cancer and breast cancer, there is reflex FISH or ISH testing to determine whether there is any amplification in HER2, and those are HER2 amplified patients. So I'm going to use that terminology very interchangeably about overexpression and amplification, but it's a protein and gene issue, so just keep that in mind. So when should HER2 be tested? I think HER2 should be tested in all patients with colorectal cancer right at diagnosis. There are various criteria for HER2 testing. HERACLES was one of the first trials in HER2 colorectal cancer, and they established this criteria about IHC being 3 plus, the number of cells was about 50%. But bottom line is that all of this testing can be performed by the pathologist, but our challenge is not really the issue of the fact that there are challenges with this testing. The issue is that most people are not testing it, right? So test with whatever CLIA certified assay you have, but test early and test frequently. HERACLES was the first study which showed that dual anti-HER2 therapy in colorectal cancer works. So this is a key difference between breast cancer, gastric cancer, and colorectal, is that single agent trastuzumab, whether combined with chemotherapy, is not effective and should not be used in HER2 positive colorectal cancer. In HER2 positive colorectal cancer, you need at least dual HER2 inhibition with trastuzumab and a TKI, whether it is lapatinib, tucatinib, or an antibody like pertuzumab. So in the 7-year follow-up, you found a response rate of about 28% in a highly treatment refractory population, which would be right now eligible for salvage therapies like Bev-TAS, regorafenib, and fruquintinib, with response rates that are less than 5%. And the median PFS was about 4.7 months. So this was a good study to start us down the road of precision medicine. My pathway was a study with, again, dual anti-HER2 inhibition, but this time, instead of using lapatinib, they used trastuzumab and pertuzumab. This was a US study, and because our experience was evolving, this study allowed both KRAS mutants as well as wild-type patients. And it actually gave us an important lesson that when you look at RAS wild-type patients, there is good activity, response rates of about 40%, but the response rates were negative in patients that were mutated, right? And this showed us that very much like EGFR inhibition, because it's an upstream issue, HER2 inhibition is not going to affect patients that are RAS mutant, right? So RAS, BRAF wild-type patients who are HER2 overexpressed or amplified should be treated with trastuzumab and another HER2 inhibitor, making it a dual anti-HER2 inhibition. So Mountaineer was the key trial that put the first approval of a HER2-targeted agent in colorectal cancer. And what they looked at was they looked at central testing as well as local testing. They looked at blood and NGS, blood NGS, tissue NGS, IHC versus tissue NGS. And bottom line of this slide is no matter what test you use, there's good correlation and concordance. So test whatever is available, but test for sure. This is the phase 2 Mountaineer study. So it started as a single-arm study with trastuzumab and tucatinib. And then there was a non-comparative randomization to trastuzumab, tucatinib versus tucatinib alone. This was after the fact that we'd already known that single agent doesn't work, but this was mandated to prove the proof of principle, and it actually gave us an important lesson. These were all second-line or more patients who had received prior chemo. This is the final analysis, which showed an objective response rate of 39%, but look at the median duration of response. It was as long as like 15 months. So when these patients respond, they respond very well and for a long period of time. And median PFS was about 8.1 months and a median OS of 23.9 months. This is staggering for a treatment refractory colorectal cancer. Furthermore, not only was this an effective regime, it was also a fairly well-tolerated treatment. So you can see that most common treatment-emergent adverse events that occurred were either diarrhea, fatigue, nausea, but majority of them were grade 1s because you can see the amount of orange on that slide is very minimal, right? So those were grade 3s. And the most common tucatinib-related adverse events were diarrhea, fatigue, and then some ALT increase, which was asymptomatic. So Mountaineer results, they did vary with when you looked at blood NGS and tissue NGS. So when you look at the PFS in patients that were found to be amplified on tissue, the PFS was about 10.1 months compared to 8.1 months when it was blood NGS, and the objective response rate was also slightly different. Now, this could be related to the fact that sometimes blood NGS can actually pick up low-level amplifications or sometimes not even, or amplifications that are not focal, but a chromosomal level. So in those cases, perhaps, or hypothetically speaking, HER2 is not the driver mutation, it's just one of the resistance mechanisms. So when you look at SWOG 1613, this was a study that was designed to answer the question whether HER2 amplified patients respond better to HER2 therapies or they respond better to anti-EGFR therapy. This question arose because we found that HER2 amplified patients do very poorly on anti-EGFR therapy with limited response rates and limited PFS. So this study enrolled patients that were HER2 amplified into trastuzumab, pertuzumab, the treatment arm from MyPathway, and cetuximab irinotecan, which would be considered the standard of care because these patients are RAS, BRAF wild type. And then there was a crossover that was allowed. So the primary endpoint of the study was not met. It was also a slow accruing study because of the rare prevalence of this biomarker. So the study could not show superiority of TP over Satiri. But there were some really key important lessons that we found in the translational aspect of this study. So when you look at this slide, it's a little busy, but what I want you to concentrate on is when you look at high gene copy numbers or high HER2-CEP ratio, which means that your gene amplification is high, you respond very well to TP, which is dual anti-HER2 therapy, and very poorly to Satiri or anti-EGFR. And the vice versa is true whenever you have low-level amplifications, right? So it almost seems like HER2 amplifications, unlike mutations, is not a binary concept. It's not like you have an amplification and you don't have an amplification, but the level of amplification can decide how to personalize your therapy. There are some low-level HER2 amplified patients where their tumor is not as addicted to HER2 as possible, and therefore anti-EGFR can actually make any difference. So when you look at these response rates, you can see the highest response rate is seen in patients that received TP and had a really high gene copy number or high HCR ratio. So this is an important slide because it tells us that there is still some personalization that can be done in this therapy. So now coming to the second drug that's currently approved in colorectal cancer, and this all started with DESTINY-CRC01 study. We've already known that the compound here is trastuzumab deruxtecan. This is an antibody drug conjugate. The major mechanism of action is targeted delivery of chemotherapy, and therefore its efficacy would be based on target expression theoretically. However, because of our earlier experience, this study was done in RAS BRAF wild-type patients, as was the case with Mountaineer and HERACLES study, with the primary endpoint of confirmed objective response rate. This study was enrolling 3 different cohorts. The first cohort, which is cohort A, is what we call as classically HER2 amplified or overexpressed tumors. These are very similar to TOGA, HER2 3 plus IHC or HER2 2 plus IHC, but they have to be FISH positive. And then there was a cohort of HER2 low tumors because the drug was showing activity in breast cancer in HER2 low tumors. So this is the waterfall plot, and you can again see a very impressive response rate, close to 40% for patients that were highly treatment refractory. What is also key is some of these patients had already received a prior HER2 therapy, and you can see when you look at the subgroup analysis, the response rates don't really change when you get a prior chemotherapy, which is very much similar to the experience we've seen in breast and gastric cancer, that if you change the mechanism by which you're attacking HER2, you still retain activity as long as you retain HER2, right? Another thing that we saw in this was there was a clear separation of patients that had HER2 IHC 3 plus and HER2 IHC 2 plus and ISH. And you can see majority of those responses are occurring in patients that are HER2 3 plus. So here, the level of expression is what is determining the response to the drug. So when you look at the PFS, it shows very much the same thing. When you look at the median PFS in the HER2 3 plus cohort, it is significantly better, about 6.9 months compared to 2.1 months for a HER2 2 plus case. And the same thing goes through for overall survival, 15 months versus 7 points. So doubling of survival because of this. So now we are going to DESTINY-CRC02 study. So this was the second version of CRC01 study, and there were key differences in this, right? One of the differences was that while this study was being designed, we were finding that a lower dose of trastuzumab deruxtecan would be better tolerated, especially with regards to ILD, as was discussed. And the second thing was we had excluded patients with RAS mutations because they don't work with dual anti-HER2 inhibition. However, because this is a different mechanism of action and it's a chemotherapy action, it's not dependent on your pathway addiction. So we allowed RAS mutant patients in this. So these were the 2 key differences in this study. So there was a randomization to the two doses, 5.4 and 6.4. There is different approvals for trastuzumab doses. For example, in breast cancer, the 5.4 milligrams per kg is the standard dose to be used every 3 weeks. When we look at the objective response rate, we find that the objective response rate was 37.8 compared to 27.5 in the higher dose. Therefore, it didn't seem that there was any compromise of that response rate by dropping the dose. The median duration of response was very similar. The disease control rate was about 86%, and the median PFS was comparable between the 2 arms in this study. Hence showing that 5.4 milligram per kg is a very efficacious dose in colorectal cancer. Now, this is the key slide in this, and one of the major toxicities with the drug can be interstitial lung disease. And when you look at the differences between the 5.4 and the 6.4 milligram doses here, you can see that there was a difference of any grade of ILD between 12% all the way to like 8%. But more importantly, almost all ILDs that were seen with the 5.4 milligram dose were grade 1 and grade 2. So we didn't see any grade 3, grade 4, or grade 5 toxicities with the 5.4 milligram per kg dose. This is a very busy slide, but bottom line of this slide is that the side effects of this drug are very similar to that of chemotherapy. It's already been discussed. There are no new safety signals when it comes to treatment of colorectal cancer, proactive management of nausea and making sure you use GCSF support whenever needed for neutropenia would be ideal for this study. When you do a subgroup analysis of CRC02, we found some, again, similar results that we had found previously in CRC01, that even though patients had had prior anti-HER2 therapy, they had very similar responses to trastuzumab deruxtecan. To be noted, this study did require a baseline biopsy and confirmation of HER2 before enrollment. Another thing that we found was that the left and the right-sided colon cancers responded equally well. This is a little bit different from dual anti-HER2 inhibition, where the right-sided tumors don't respond as well. We also found that the responses were seen in patients that had RAS mutant. So if you today have a clinical CRC patient who has RAS mutation and a HER2 amplification or overexpression, trastuzumab deruxtecan would be the first-line treatment for that. It would be the first anti-HER2 treatment, because dual anti-HER2 inhibition is not going to work in these patients. We also found that there was, again, a very stark difference between the responses that were seen in IHC 3+ population, where the response rate is almost 50%, compared to IHC 2, where the response rate is 5.6%. So I think the IHC 2+ is the area of great unmet need for this population. I'm going to now take you through a journey of like a patient with HER2 positive tumor. We've seen the firsthand effects of the impact this newer therapy and precision medicine colorectal cancer can make to some of these patients. I have a few patients who have been on literally every clinical trial for HER2 disease and have had really long-term survival. So this was a 60-year-old patient, no allergies, was a RAS BRAF wild-type patient, proficient mismatch repair, has metastatic disease. When you look at the, so diagnosis was stage 4 sigmoid colon cancer with liver metastases, was rightly so started left side RAS BRAF wild type, but nobody did HER2 testing, but started on panitumumab and FOLFOX chemotherapy, had partial response, confirmed partial response, and then ultimately, as expected, had surgery. The surgery showed adenocarcinoma, again RAS BRAF wild type. Then they did, he had progression, got second-line treatment with bev-folfiri. Finally, somebody did IHC HER2, which was 3+, and then they were on a clinical trial with dual anti-HER2 blockade back in 2023, had a partial response, had progression again in July 2024. So, and this particular patient on follow-up was also subsequently on DESTINY-CRC one study, and again had nearly a year survival with that. So I think multiple lines of treatment have improved survival of HER2 positive metastatic colorectal cancer. So the three key points here is for this patient, earlier HER2 testing would have been optimal. Whenever you confirm it early, it can help with earlier use of anti-HER2 therapy, plus moving these patients towards clinical trials, because these are rare CRC patients and extremely valuable. Clinical trials testing trastuzumab or T-DXd based options could have been considered, allowing for either earlier use of HER2 or clinical trials. So final thoughts on this is HER2 amplification is an actionable target. It should be tested in all patients with metastatic disease right at the onset, at diagnosis. It can be tested with either IHC, ISH, or NGS. It is seen predominantly in RAS BRAF wild-type patients, but can be seen in patients with concomitant RAS mutations. There are several anti-HER2 therapies that are currently available. Trastuzumab tucatinib is approved for RAS BRAF wild-type colorectal, HER2 amplified colorectal cancer. Trastuzumab deruxtecan, the ADC compound, is right now approved for all HER2 3 plus IHC, irrespective of RAS mutation status, and it retains activity in patients who've had prior anti-HER2 therapies. So I'll stop there and Shiva.
Thank you. Thank you, Raghav. Moving ahead to the finale. So I'm sure you guys are ready to get out of here. Second day of Ask a GI. Like these mics here, makes us look like a boy band. Dr. Koo with the lead singer.
Well, we have a dance at the end, so please stay.
Unique setup. So I'm going to talk about something really interesting and exciting about what's going on in the world of biliary tract cancers. So in the US, it's a rare disease, right? So we don't really see a lot of biliary tract cancers in our practice, but this is common in Asia. So, and in different parts of Asia, you can have more intrahepatic cholangiocarcinoma, or let's say in case of India, you have an increased percentage of gallbladder cancer. So it's a really global disease, but the great thing about biliary tract cancers is that really a decade back, there was nothing for it, and now we have immunotherapies, targeted therapies. Really, the power of NGS has been translated into biliary tract cancer. So I'm going to talk a little bit about that. So first of all, biliary tract cancer is not one disease. So think about it as different diseases. Three big subsets. You have extrahepatic cholangiocarcinoma, so everything outside the liver. You have intrahepatic cholangiocarcinoma. That's classic when you see this big lesion in the liver, then other small lesions. Folks often think that's colorectal cancer, or used to call it carcinoma of unknown primary. That can be a common misdiagnosis. But really, these patients with cholangiocarcinoma or intrahepatic cholangiocarcinoma. And then you have the third one, which is gallbladder cancer. And there are differences in the way they present clinically. So gallbladder cancer is a little bit more aggressive. When you look at it, really when you look at the immunotherapy data, which I know we're not just discussing today, but really immunotherapy really doesn't seem to be that great in gallbladder cancer. Maybe they're the ones who are more aggressive, need a chemotherapy. There was a study, GEMCIS versus GAP, which is a negative study, which is Gem/Abraxane cisplatin. But the interesting thing was the subgroup in that which actually was the gallbladder cancer cases. And why I tell you that is because it's a different cancer, potentially, than your intrahepatic cholangiocarcinomas and extrahepatic cholangiocarcinomas. And the big difference is the molecular markers. So think about it as, we have the two big ones, which is FGFR fusion and IDH1. This was before HER2. So the FGFR fusion and the IDH1 are mostly in intrahepatic cholangiocarcinomas, all right? And then when you look at, let's say, KRAS, which is also a target which is expressed 90% pancreatic cancer. As if you walked around, there are a lot new KRAS inhibitors which are coming out. So RAS inhibitors are coming out. So about 30% of extrahepatic cholangiocarcinomas can be KRAS mutant, and these potentially can have a worse prognosis than other subsets of cholangiocarcinomas. The FGFR fusions actually have a much better prognosis. And the third one is gallbladder cancer. And gallbladder cancer is unique because it can have increased HER2 amplification, up to 30% of cases. So when you look at gallbladder cancer, you have gallbladder cancer, which is the most HER2 amplified, then is extrahepatic cholangiocarcinoma, and then is intrahepatic cholangiocarcinoma. So if you have a patient present with gallbladder cancer, you gotta test them. You should test all of them, but really you have to test the gallbladder cancer patient. So, we've talked about this. I won't go a lot into it. Jeffrey kind of talked about it. Raghav also went through it. Essentially, we're really discovering what do we call HER2 amplified. For us at Anderson, it's more using the gastric kind of guidelines. Sometimes in biliary tract cancer, you do not have enough tissue. But really, you should be doing so. For us at Anderson, we would do, if you have a biopsy, we would do the next-gen sequencing in these patients, and we also do the HER2 IHC. I think that's important, and I'll talk a little bit about why you should be doing it. So this is just giving you some context, because you'll see some data in this kind of second after first-line therapy for biliary tract cancer. So this is just giving you some context. So this is ABC-06, and this was a trial in second-line biliary tract cancers, which compared FOLFOX, standard of care, kind of to placebo at that time. And as you can see where that arrow is, you see the response rate is about, the response rate is about 5%. So not great with second-line therapy. So we really need newer therapies, better therapies for these patients. And how do we get there? So coming to HER2 amplified biliary tract cancer. So most of the trials which have been done are part of basket trials. Again, rare tumor, so you kind of do it in terms of basket trial. You know, Raghav showed you some in colorectal cancer. So this was my pathway, which was different cohorts. HER2 amplified colorectal cancer was one of them. So this was pertuzumab and trastuzumab that we use for breast cancer. In this basket trial, showed an overall response rate of 29%. All right, so in this there were about 39 patients with HER2 amplified metastatic biliary tract cancers. So not big numbers, but showed this response rate of 29%. Kind of moving on to this, this is kind of the, using this analogy, a new kid on the block, right? So Destiny Pan-Tumor 02, and we've talked about T-DXd, trastuzumab deruxtecan, and this is a pan-tumor trial. So again, a basket trial, a pan-tumor trial of different malignancies, endometrial, cervical, ovarian, bladder, other. Also had a pancreatic arm, which really did not do that well. And as you can see, these little arms, so the orange is IHC 2+. Okay, and I'm going to focus on BTC because we're talking about biliary tract cancers. So as you can see, interestingly, we really think this drug is really powerful in HER2 amplified disease, but for HER2 2+, there's actually no responses. And if you really look at the HER2 3+, similar to colorectal cancer, that is where your responses lie. So if you take back nothing from this talk this evening, remember HER2 3+ IHC is where all the action lies in this disease, just like other tumor types. So HER2 3+ had a response rate of 56% with trastuzumab deruxtecan, and when you look at all, it was about 22%. And why is that important? Because you look at the accelerated FDA approval, which came out for adult patients with unresectable or metastatic HER2 positive with IHC 3+. Remember, this is not for IHC 2+, solid tumors who have received prior systemic therapy and have no satisfactory alternative treatment options. So this gained accelerated HER2 approval in this disease type. So what's the next step? Obviously, you get the accelerated approval. Now you want to get the approval, full approval for the disease. For that, the companies have to launch their pivotal trial, and this is the pivotal trial which just is launching right now. This is unresectable, previously untreated, locally advanced or metastatic BTC. They're doing it for HER2 expressing IHC 3+ or 2+. However, the primary objective, interestingly, is the overall survival in HER2 3+ disease, right? Because that's where they see the advantage. This is a T-DXd is combining with the bispecific bispecific. I can never say this name, rilvegostomig. It's getting more complicated as we're getting more and more drugs to talk about this, talk about the names, but bispecific TIGIT versus T-DXd versus gemcitabine cisplatin durvalumab, which is a standard of care. Obviously, you can use pembrolizumab also, which is another standard of care. But this is the confirmatory trial, global trial, 620 patients, a fairly big trial, 3-arm trial in this kind of rare cancer. Most of the enrollment probably is going to be ex-US in this trial. Coming to another one, which also Raghav showed, is the tucatinib plus trastuzumab. Again, this was part of a basket trial, and this had an overall response rate of 46.7%, so a fairly robust overall response rate, and a median duration of response of 6 months. Obviously, the number of patients in this was about 29. If you really look at this BTC trial, essentially there again the number of patients were not were in double digits but lower, and when you look at this, there were again 29 patients. Again, remember the pertuzumab, trastuzumab was about 39 patients, right? So the numbers are lower because these are kind of basket trials, and this was tucatinib plus trastuzumab. Again, side effect profile, again mostly grade 1 and 2 in the teal, and then grade 3, in the blue, and one of the main tox is diarrhea, but can be managed with antidiarrheal medications. All right. Coming to another, so it really, like, you think about this is, again, explosion of HER2 target therapies in different cancers. So really kind of like, everybody follows breast cancer. Like, so 2 decades after breast cancer, almost 3 decades after breast cancer, we're finally trying it in different diseases, seeing that it really works in these diseases also. This was a trial called Horizon BTC-01, a global trial of zanidatamab monotherapy in HER2 amplified BTC. So what is zanidatamab? It's a bispecific HER2 agent. So it binds to two domains on HER2 called extracellular domain 2 and 4. And essentially it binds to the domains that trastuzumab and pertuzumab binds, but it's a different drug. It really, that binding really gives it, I think, enhanced properties. In preclinical models, it gets better receptor internalization. So it's a different drug. And clinically, and I'm going to show you some data, actually is clinically, they haven't compared head to head, but seems to be at least efficacious than just pertuzumab, trastuzumab given together. And I can tell you from anecdotal, in my practice, when I've given trastuzumab, pertuzumab before, and I gave patients Zani on clinical trials, seems to be a better benefit for these patients. But again, no cross-trial comparison, and this is anecdotal from my practice. So coming to this trial, this was a global trial. So remember, everything else was basket trials, right? So I showed you tucatinib, trastuzumab, I showed you pertuzumab, trastuzumab, I showed you DESTINY, trastuzumab, deruxtecan. This was actually a trial for only biliary tract cancer patients. Tells you that it is possible to do trials of rare tumor types or rare, amplifications in tumor types if you do global trials. So this was zanidatamab. This is single agent given day 1 and 15, and the primary endpoints were overall response rate with the key secondary endpoints of duration of response, disease control rate, progression-free survival, and overall survival. This trial incidentally had its global launch in February 2020. So kind of dramatic drum roll, COVID right after that. So it took, but interestingly, just in 2 years, it actually accrued globally. And when you look at the confirmed overall response rate, now this is in all patients. So the patient population was HER2 amplified BTC, and those were IHC 2+ and 3+. Again, both of these were there, and they had to be ISH positive, so in situ hybridization positive, IHC 2+ or 3+. And in both IHC 2+ or 3+, you had a 41.3% confirmed overall response rate. And really look at this graph, you look at this light blue, dark blue, what this tells you is one is gallbladder cancer, one is intrahepatic cholangio, extrahepatic cholangio. All different subtypes seem to get a response or seem to get some kind of benefit, let me say, with this agent. So it didn't matter what subtype were you, in a way, gallbladder, intrahepatic, extrahepatic, everybody seemed to get some kind of benefit from this therapy. And coming to this horizon, we did the long-term follow-up in ASCO this year, last year, which was 2024. And this was sort of median overall survival. So these patients were after frontline therapy, right? So they got GEM-CIS mostly, about 25% got some checkpoint inhibitor because this trial was done, remember, before durvalumab or pembrolizumab was approved, right? So there was 25% patients did receive checkpoint inhibitors, majority received some kind of platinum like GEM-CIS. The median overall survival, and this is second line and beyond, was about 15.5 months in these patients. Interestingly, for HER2 3+, again, most of this benefit, the overall response rate, remember I told you is 42%, most of this benefit was run by HER2 3+, right? And which was 52%. So 52% benefit, response rate HER2 3+, 5% HER2 2+. So again, seems to be mostly driven, benefit seems to be driven by HER2 3+ disease. Interesting thing about this trial was the duration of response. As Raghav mentioned in his trial, in his lecture, that the patients, so let's say 42% patients got response, but the duration of response was 14.9 months. It was pretty remarkable that these patients, which had a 5% response rate, but these patients, once they started responding, so some people, we put them on the trial and they did not respond, their progression in 2 months. So that's where your median progression-free survival comes down, right? But the duration of response is you see that patient, they get a response, and you want to continue to see the response, right? Because if they get a 40% decrease in their target lesions, and then the next scan in 2 months, they get a 20%, 30% increase, that really didn't help the patient. It makes the waterfall look really pretty, but it really didn't help the patient, right? Because they're coming off the drug in 4 months. But this duration of response is really important. So in this trial, the important thing was duration of response was actually 14.9 months. I had a patient who finished like the whole 2 years of the trial with metastatic, BTC. So it's really the durability of response is important in this. Long-term profile. So essentially, this was mostly it's a kind of a and I've given it to a handful of patients. Part of the clinical trials, I was part of the phase 1 zanidatamab, and so I've given zani for about 6, 7, 8 years now. And really, it's a well-tolerated drug. It's like diarrhea, infusion reaction, one of the reactions, but we once we pre-medicate everybody with like Benadryl, a PPI, steroids, they do fine. They really don't tend to have, just grade 1, 2. Not a concern. The diarrhea is one of the main side effects, but you really have to pre-medicate the patients, give them Imodium, Lamotril, just educate them. So mostly with Imodium, diarrhea was tolerated. So it's actually a fairly well-tolerated drug. One patient I think had an LVF decline, which was why they were discontinued, but really fairly safe drug. Did not see a lot of declines in their ejection fraction. So now we've started this global phase 3 trial in which again. This is essentially simple. It's split into chemo plus checkpoint inhibitor with or without zanidatamab. So kind of simple trial. And patients, again, can be HER2 3+ or 2+ in a way. But again, primary endpoint is progression-free survival in patients with HER2 3+ tumors. They were taking both, but really it's in HER2 3+ tumors. Global trial started accrual a couple of months back. Accrual has been going well. Interestingly, in this trial, because we recognize, patient comes to you with cholangiocarcinoma, you want to treat them, right? You don't want to wait for the NGAS HER2, though you can get it quickly. We actually allow the investigators to give a few cycles of chemotherapy before they introduce the zanidatamab. So that kind of gives you more flexibility so the patients can get started, and then if it's HER2 amplified, then you can add on the zani. So kind of a different kind of trial design just to make it more physician and patient friendly, because again, it's a rare patient population. So closing out, I'm just going to quickly talk about other data. So this was a study from India, single center. They accrued these HER2 positive BTC. Patients were accrued 90 patients, single arm trial, which was trastuzumab with gemcis, right? And as you can see, the overall survival, at 12-month overall survival is 39.1%. However, this is better than historical control. So it was single arm, but it was better than historical control. Gallbladder cancer, again, most 95% of patients on this trial were gallbladder cancer, traditionally more aggressive disease than the other, intrahepatic, extrahepatic that I've talked about. This is a trial of FOLFOX plus trastuzumab, again in the second line setting. Again, this is just as an FYI. Again, overall response rate, 29%, median progression-free survival, 5.1 months. I feel like you have better options after the frontline setting, which are chemo-independent options, but trastuzumab deruxtecan is kind of like chemo, but not really, right? So what are the take-homes for targeting HER2 and BTC? Again, remember, it's not one disease. They're different diseases, intrahepatic cholangiocarcinoma, extrahepatic, and gallbladder. Please do NGS on all your patients. If you do the first biopsy, tissue is not sufficient. If you can get another biopsy safely, please do get that biopsy because their treatment may change. I've had patients that I've treated, they've gotten a biopsy, we didn't get tissue, and we kept on treating them. They didn't want to get a rebiopsy. At progression, I biopsied them. They had an FGFR fusion. So it's like there's different things that can be done in these patients. So HER2 is amplified or overexpressed in approximately. It's higher than that probably. It's probably 20 to 30% of gallbladder cancer, about 10% of extrahepatic cholangiocarcinoma, and 5% of intrahepatic cholangiocarcinoma. Remember, there are 2 drugs which are approved now, HER2 3+. Again, antibody drug conjugates like trastuzumab deruxtecan, and a bispecific biparatropic antibody. Remember, this is not a classic bispecific like lymphoma that patients get CRS. You do not get cytokine release syndrome. The mechanism is completely different, so it's better to call it biparatropic. But folks want to call it bispecific, kind of, because people know that, but no CRS, remember, you don't have to worry about that. And the great thing is that numerous novel target therapies are on the horizon for patients with advanced BTC. And there are 2 frontline trials which have been initiated, which is great for this, which is great in 2 different indications, one trastuzumab deruxtecan and one zanidatamab. So thank you so much for listening and hanging in to the bitter end. And we'll pause there and see if you guys have any questions for us. Thank you so much. Thanks, Jeffrey.
Yeah, so we actually have a really good number of questions. We'll start going through them. So the first question I think is for me. What is the current status of the phase 1b/2 DESTINY-Gastric 03 study? Do you think there will be approvals on the horizon? So just as a reminder to the audience, this is really more of a signal-finding study where T-DXd is now being combined with chemotherapy, but also immunotherapy combinations in both the second line and first line. And actually, it's for HER2-positive tumors, but also this entity of HER2-low tumors, which is HER2, IHC 2+ FISH negative, IHC 1+ FISH negative. So I think the recent updated data that were just presented at this conference essentially showing a pretty high level of activity, but there is also pretty high, there's also substantial toxicity. And again, one thing to remember about T-DXd is that it is a chemotherapy-containing molecule. So, it would be hard, for example, to combine T-DXd with first-line FOLFOX. So instead, they've combined it with fluoropyrimidines. So yes, there is activity, and I think ultimately the goal is to select kind of the most promising doublet, potentially to take into a first-line study. So I do not expect that there would be any approvals based on, a phase 1b/2 study. It really is more to identify the most promising, most active, most tolerated compound to take forward into phase 3. So the next question is something that I'll open up to both, Raghav and Shubham. And it's kind of a follow-on from the previous question, is there a rationale for using T-DXd in the first line for any GI cancers?
I think that there is a rationale. I just don't think that there is any data so far. I'll talk about colorectal cancer. I think in colorectal cancer, first-line response rates with standard first-line treatment would be somewhere between 40 and 50%. I think T-DXd in a second and third-line setting gives you that response rate if in an appropriately selected group. So I do think that there is definitely an advantage to bringing something like that in the first line, but we don't have that evidence as yet. In the absence of that evidence, I think appropriate sequencing and proper selection can still improve outcomes.
Maybe to push you a little bit further, and again, it really is similar to the gastric story. I mean, would you offer it as monotherapy? Would you combine it with a fluoropyrimidine? Would you add bevacizumab? I mean, what would your ideal study design be?
Yeah, so I mean, if there was a first line study, I think a fluoropyrimidine combination, VEGF is definitely a biologic that could be attached to it. Unlike gastric cancer, though, I do feel there is an option of adding this drug to a FOLFOX-based regime. It is actually, there is neutropenia, there is definitely thrombocytopenia, some degree of anemia, but we've combined FOLFOX with irinotecan, and systemic irinotecan has definitely a lower therapeutic window than T-DXd. So I think that there is definitely a role of combining it, but frankly, my interest would be more towards coming up with other combinations that can enhance the activity, and especially in the HER2 plus group where the activity currently is limited.
Yeah, I think, again, like Raghav said, it makes sense in a way, but there's no data. But I think the trials are going on, right? So that's why we move in frontline. I think really for disease like biliary tract cancer and pancreatic cancer, two diseases that I do, I think if you move them earlier, you're going to get a better patient population, more treatment naive, higher response rates. But I think I feel like moving target therapies upfront is we're going to see the breakwater data in colorectal. So I think it does make sense. You just need the data to come out.
Great. I think a follow-on question that I think all of us can answer is, what is the mechanism of trastuzumab resistance?
I'm going to presume that at least in colorectal, we're talking about trastuzumab pertuzumab or trastuzumab tucatinib resistance. So there are two mechanisms, right? There's the dual anti-HER2 inhibition and the T-DXd. I think the mechanisms of resistance would be different for both of these. HER2 loss definitely is a mechanism of resistance that can be seen in both groups. I also do feel that loss is somehow related to the length or duration of treatment, because longer treatments often are associated with more HER2 loss. But trastuzumab tucatinib or dual anti-HER2 inhibition is associated with resistance mechanisms very similar to anti-EGFR resistance mechanisms. It's activation of other mutations in that MAP kinase pathway, so you can acquire RAS mutations, PIK3CA mutations. In trastuzumab deruxtecan, we're not exactly clear, but there is some hint of evidence that there could be, rise of topoisomerase expression. There could be, increased expression of transporters or drug efflux pumps. There is also some degree of like resistance that comes up with MAP kinase pathway. But whether these are like associated with resistance or these are actually true resistance drivers, that's yet to be seen.
Yeah, I think, biliary tract cancer, again, rare tumor, so it's kind of hard to say. I think it would be kind of similar like other MAP kinase, and then, kind of HER2 loss, those would be the two. So in the trial that we did, the Horizon BTC01, we are looking at like ctDNA and everything to look for, we have that, in some patients at progression, and we'll see if there's any, other resistant mechanisms which come. But I think that I agree with Raghav, it's fairly similar when you look at even some of the breast, like the PIK3, AKT, mTOR kind of pathway.
Yeah, and I think it's the same in upper GI. But again, I would emphasize that about 30% of the time, we have clear loss of HER2. And also, I think there's a distinction between intrinsic and acquired mechanisms of resistance. So certainly in gastric, you have patients who are IHC3+, and you're very excited that they will respond, but unfortunately they have actually quite rapid progression. And I think there is intrinsic, again, RAS-RAF, PI3 kinase, co-mutations even at baseline, which predict for resistance.
I believe there's tumor heterogeneity also, right? You're seeing response somewhere and some they're progressing. Maybe the expression is not everywhere.
Although in gastric, I would point out that, as you had mentioned, the staining can sometimes be a little bit more focal, basolateral, at least colorectal, and some evidence in biliary shows that their staining is more like breast. And in breast, you go through multiple lines of HER2 therapy without significant HER2 loss.
Yeah. And both of you have mentioned IHC3+ being an issue, and some also it is an issue in gastric. I think although we've underestimated it. For example, in Keynote 811, 85% of patients actually had IHC3+ tumors. So most of them were so only 15% were 2+ FISH positive. But in the subgroup analyses, those patients clearly seem to derive less benefit. Now, we still would not withhold treatment from those patients. I think there is benefit, but just to a lesser degree. So the next question actually ties into a phrase that Shubham used. Please describe the importance of tumor heterogeneity in HER2-positive disease.
Yeah, I think it's important.
Yeah, exactly. I think it's everything we talked about. Yeah, and again, I think ctDNA may well be. I think the future in terms of all of the things that we've talked about. But whether it's quite ready for prime time. Actually, interestingly enough, so I've noticed that neither of you. So for example, biliary tract cancer is notoriously difficult. Sometimes you get an ERCP brushing. Is ctDNA something you use in your practice or would consider?
I think I would consider it. I just don't use a lot of it because there's also, unless you have like big lesions, there's also a problem with shedding. So if you have that hyalur and you're just pulling some out, problem is you're not shedding it also. You're not getting that ctDNA back. So I use it for, let's say, if you have, if I cannot get good tissue essentially, but mostly I go on the tissue testing. I'm more traditional that way, at least in biliary.
Yeah, I think in colorectal, tissue is not as much of an issue as it is in biliary or gastric, perhaps. We've used ctDNA, but I've used ctDNA more as a quick screening tool. Because, when I treat a patient with, say, trastuzumab, pertuzumab, and they've progressed, before I could get an IR biopsy, if I order ctDNA on that same day, within the next 7 days, I'll at least know. And if they're still HER2 positive, so there's good positive predictive value. Yeah. But if I don't see that HER2 amplification, I can't be sure. The other thing, I think Shubham alluded to this, is that you can order ctDNA, but you will not be able to look at the IHC status, right? Because it's only going to give you the gene status. And like a lot of times, you can have these acquired HER2 amplifications that are like really, really low level. But that does not mean that they have like IHC, 3+, which are the ones that you want to target.
Right. So I think this is actually a related question. What is the concordance between ERBB2 NGS amplification report and IHC3+ FISH+ status? And has there been a study to investigate this question?
Yeah, so we've looked at our experience in colorectal. In most cases, when you find HER2 amplification in tissue NGS, that correlates very strongly with the IHC3+. And the reason is because tissue NGS is very optimized to figure out high-level amplification. Their copy number cutoff is like 4. And most of those times that they'll have like a 3+. The ctDNA issue is a little bit different because it's harder to quantify the amount of tumor amplification in that. So there, the correlation is actually weaker.
Yeah, so we're going to look at it in our study, Horizon BTC01. We present it, later, but I agree with Raghav on that I think we need, because, it's practically people say, hey, why do I need to do a HER2 IHC? Just do an NGS and then should I really do HER2? But I would encourage everybody to do it, I think along with the NGS HER2 IHC. But I think if it's positive, really it's amplified, it should be amplified. But we're looking at that question specifically in our data set.
And I think we've looked at that as well. So I think in gastric, if your NGS shows ERBB2 amplification, almost certainly the tumor is HER2 positive. On the other hand, some HER2 positive tumors, when we perform MSK impact, you don't necessarily see HER2 amplification, or you see that it's below the cutoff where it would be called amplified. So I think FISH is potentially more sensitive and more focal than NGS. And again, that may be related somewhat to also maybe intratumoral heterogeneity. But again, I think the gold standards are there for a reason. We should kind of start with them and then kind of take it from there. Next question. It was stated that loss of HER2 positivity was associated with resistance to HER2-directed therapy. What's the difference in response to T-DXd in patients who had HER2 loss versus the ones who had not, possibly based on DESTINY-Gastric 01? Sure, I can take it from DESTINY-Gastric 01. So again, I think DESTINY-Gastric 01 did not mandate a pre-treatment biopsy prior to third-line therapy. But I think about 30% of patients did have HER2 positive, did have testing, and I think essentially it confirmed. That I think if in patients who had testing and who had HER2 positive disease, they had higher response rates than if not. So I think therefore it remains. Certainly it remains my practice and my recommendation that whenever possible, try and determine that the tumor is still HER2 positive before considering HER2-based therapy. I don't know whether either of you have any additional thoughts.
Yeah, I don't think CRC01 or O2 studies, which are the only ones that show the sequential effect of HER2 therapy, they can't answer that question because the criteria was you need to have HER2 positivity on a fresh biopsy. Right. So if there was loss, we don't know.
The same thing for like Zani, they had to have HER2 amplification by, HER2 and plus ish. Right.
So there's actually lots of great questions, but I think we're out of time. So I'm going to take one other question that potentially, I think, would be open to a lot of discussion. What are your thoughts on potential combination of zanidatamab and trastuzumab deruxtecan, given the outstanding efficacy seen with both compounds in GI indications?
So I can take that question. So I think, I've treated patients with both trastuzumab deruxtecan, and I get this question of like, how would you do it? Like, what's the sequencing, right? Both are kind of in the same wheelhouse. And when I talk to my breast cancer colleagues who've been giving T-DXd, trastuzumab deruxtecan for a long time, they're like, hey, patients tolerated well, but there seems to be different toxicity depending on the tumor type. So I feel like lung, you can see more, I think, fibrosis, idiopathic pulmonary fibrosis, maybe in lung cancer, right, when you use trastuzumab deruxtecan, than maybe in breast cancer. In biliary, what I found is that patients are coming off Gemcis Durva or Gemcis Pembro or something. They're getting, they get this recurrent cholangitis, stents are placed and everything. I see, maybe and it's like a chemo, it's not like they're coming off a chemo, they go on a chemo basically, yes. So it's like nausea, so it kind of seems to be a little bit more, at least in the patients I've used it in. Zani seems to be a little bit better tolerated and better easily combined. So look at the trials that are being done, which will tell you your answer, is the trastuzumab deruxtecan is combined with an immunotherapy, yep. Right, to bispecific, but Zani is being combined with Gem, Cis, Pembro, like with all the chemo. Yep. So it's actually fairly easily combinable. Like I said, the main tox was diarrhea. So it seems to be, patients once you get the side effects, they really honestly do not feel the drug. Like they just come every couple of weeks and get their infusion. So I think it's just more easily combinable, and we can see that because of the trials which are being done.
Oh, I actually think that's a great response, and I absolutely agree with the differential toxicities. I guess the question was, would you envision a study where you combine them both?
Oh, combine them both? Yeah. No.
So this question brings up a very important issue that, HER2, we've made a lot of progress, but we're not there, right? There are lots of patients with our HER2 positive that are not getting responses. So I do feel that synergistic combinations should be tried. There is some data, for example, about changing receptor internalization dynamics using TKIs. This has been done in lung cancer. And if you can change that receptor dynamics and internalize more, there is a possibility that you could actually deliver more chemo from T-DXd. So those are reasonable. There are combinations of T-DXd with DNA damage repair inhibitors that's ongoing because that's the mechanism of action of the payload. I'm a little concerned. Theoretically, I don't have any preclinical data to show this about giving a bispecific along with T-DXd, because is there a possibility that there could be some change in receptors? There could be, but there could also be a competition for like target engagement.
That would be my concern.
And you don't want to do that for a drug where the major mechanism of action is based on target engagement.
You might do Zani to catnip, like in a way, right? That could be something potentially if the toxicity, diarrhea can be overcome, but that's something.
Yeah, I mean, the diarrhea would be, but that would be exactly my concern. I think if one of the mechanisms of zanidatamab is that it facilitates better internalization, then there's no HER2 on the tumor, and there's nothing for T-DXd to bind to. So, I mean, it's an interesting thought, but I clearly would have to be backed up by good preclinical data for us to kind of launch something. And we also would have to get two major pharmaceutical companies to, to agree to.
That's the main problem.
Yeah, that's. Okay, this concludes the program. Thank you very much for joining us.
Thank you.
Thank you all.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by independent educational grants from AstraZeneca and Daiichi Sankyo Incorporated. To access all materials for this activity, visit peerview.com/XJJ860.